Okay, guys, thank you so much. I want to congratulate, Dr. Shekhar and the entire team in Bombay for actually introducing this national symposium on drug elution. I think it's one of a kind, and I want to congratulate all of you for talking about something that is very, very dear to the future of critical limb ischemia and limb salvage. So my topic for today is basically to delve into the concept of biodegradable drug coated scaffolds. And if you look at the history of revascularization, not only of the lower extremities, but also of the coronaries, you will realize that obviously balloon angioplasty has been the gold standard for a very, very long time. And then, of course, stents came in. And then, of course, drug elution and drug eluting stents came in. And of course, there are problems still. We still don't have the absolute right answer to maintain patency of any revascularization. FOBA obviously is compromised by re-narrowing due to elastic recoil, acute closure, dissection, remodeling, and neointimal hypoplasia. The second revolution was obviously bare metal stents, but there is still a very high incidence of in-stent restenosis. And now we have drug-eluting stents, basically the Zilver as well as the Eluvia stent. But these stents still leave permanent metal implants inside the vessel with potential future problems such as fractures and others. So, where is the goal for improvement? And the ideal design is to create a bioabsorbable stent design. It should have mechanical properties that will support the vessel and keep it open during that required period. It must be biocompatible. It should have adequate degradation and disappear without creating any intense inflammatory response. And obviously, it has to have good deliverability and should be able to carry on an anti-proliferative drug in order to reduce restenosis. So these are the advantages of bioabsorbable stents. What they potentially do is they delay endothelialization, they decrease the chronic inflammatory response and the localized hypersensitivity reaction. They return the vessel to probable normal vasomotion and prevent late luminal enlargement, expansive remodeling. And in addition to that, these advantages of bioabsorbable stents decrease the problem of jailing the ostium of branched vessels, as we see with metallic struts sticking into the vessel. So the scaffold is basically a polymeric stent, which is made of polyl lactic acid, PGA, or even PDLA, PCL. These are basically long chains that get hydrolyzed and basically eliminate via the Krebs cycle, which we used to study in medical school for a long time. And the degradation of polymeric stents vary between 6 to 24 months. The other scaffold is metallic stents, and these are basically magnesium alloys. They have very low elastic recoil, and the degradation ranges from 60 to 90 days, with the overall integrity for almost 28 days. So this is the scaffold. These are the kinds of scaffold. And obviously you can put different drugs on it, including everolimus or even sirolimus. In the United States, we have the Abbott Esprit BTK system that is FDA approved. I think it was approved in April of 24 last year. And I've had the opportunity of being one of the first to deploy this stent, especially in Arizona and our institution. And we've done probably about 10 cases so far. You got to remember, these stents are still extremely short and extremely narrow in diameter. And so you have to pick and choose your patients very carefully, in addition to the cost of these stents too. And that's our first stent that we put in. So let's look at why we are looking at these technologies, because the impact of critical limb ischemia is extremely well known. There are almost 150,000 amputations, but I'm not saying that these drug-eluting or biodegradable, bioabsorbable stents will completely decrease the levels of amputation, but it's another tool in your armamentarium to maintain patency and hopefully do further limb salvage and decrease amputations. But this is not the only way. You also have to survey these patients. You also have to do bypasses. You have to do reinterventions and follow these patients very closely. Critical limb ischemia, obviously, is almost the second cause of death after lung cancer. And there's a huge amount of expense, almost $12 billion attributed to critical limb ischemia. Annual cost per patient is about $35,000 in the United States. So if you revascularize these patients, there's definite improved survival. The amputation rate, quality of life definitely increases. And you can see with endovascular revascularization, there's the amputation rate has actually gone down to about 6.5% too. The problem with below knee revascularization is we do not have any technology, even bare metal stents. We've been using sometimes bailout off-label coronary stents in case of a persistent dissection, or even a covered stent in case you rupture or tear off a calcified anterior tibial vessel. And even drug-coated balloons have not given us very good results. And coronary metallic DES has limitations in below knee disease also. And the adoption of these stents in the legs is only very small. It's only about 5%. In fact, there was a trial called the PADDY trial that used coronary stents, paclitaxel eluting coronary stent systems. And the 5-year results were not too bad. I mean, it was almost, patency was not too bad at all. So what is the ideal way to maintain below knee vessels and keep them patent so that limb salvage rates can be very high? Bare metal stents, drug-eluting stents, atherectomy, lithotripsy, angioplasty, and drug-coated balloons are what we have now for BTK treatment. But to effectively treat BTK, I think what we got to do is we got to do a vessel prep, whether it be balloon angioplasty or atherectomy. And then the concept of the ideal treatment is obviously a bioabsorbable, degradable drug-coated stent. Long-term outcomes were done with reabsorbable scaffolds in patients with BTK device. The ADSORB BTK trial showed a 72.3% primary patency, and freedom from CDTLR was almost 90.7% with patient survival of greater than 50. So the term now is basically drug-eluting reabsorbable scaffold, DRS. It's not DES. It's not bioabsorbable stent. The term is basically DRS, drug-eluting reabsorbable scaffolds. And the new therapy addressing these three objectives are basically you have drug elution. Obviously, you can use everolimus or you can use sirolimus. Reabsorbable, because the scaffold has to get slowly reabsorbed, and then it provides sufficient support to prevent recoil, and then it slowly elutes. So the Esprit BTK system is the one that's FDA approved. It's basically, the scaffold is, of course, lactic PLA. It's reabsorbable scaffold. It definitely has less recoil, and it provides a platform of sustained drug delivery, and the drug is everolimus. And scaffold, as you mentioned, nothing is left behind, and therefore the vessel then goes back to its original, hopefully, structure that is originally dealt with before. So if you look at the about 4 years of treatment of this BTK system, you will see that the metallic framework or the scaffold disappears within 24 months to 36 months. Generally, at about 36 months, I think the whole scaffold is more or less gone through completely, and it reabsorbs completely, so that at 40 months, 48 months, or even 4 years, you'll see that the vessel left behind is almost like a primary native vessel. The scaffold is made of PLLA, and the scaffold contains PDLLA or lactic lactide that adheres to the scaffold. And obviously, the drug is very thin layer, 2 to 4 microns thick, and has controlled drug release. So this is the stent that we have right now in the United States. The data is extremely promising. If you were part of the study, and the scaffold gets fully reabsorbed, as we mentioned, in about 36 months or so. And you can clearly see when the scaffold begins to dissolve, it is basically converted to water and carbon dioxide via the Krebs cycle. So let's look at the data. We were part of the live BTK study. There were about 261 patients randomized. The patients who had the BTK stent were about 173. This was a 2-to-1 randomization. And these patients were followed, and you can see this article was published in the New England Journal of Medicine too. And as you go forward, you'll see most of the inclusion criteria. As you can see, the patient had a vessel diameter of 2.5 to 4, and the CLI patients basically were Rutherford 4 and 5. And there were multiple sites involved, 50 of them, and the patients were randomized into a 2:1 randomization. And more or less, in terms of the characteristics and the target lesions, they were more or less comparable, AT, peroneal, and of course, TPT and the PT. The stent diameters, available diameters are 2.5 to 3.5, and the lengths are up to 38 millimeters. And if you look at primary patency and limb salvage and freedom from major adverse events, you will see that the patency has been extremely good. If you look at primary efficacy endpoint, you see with the BTK stent 74.5% compared to plain balloon angioplasty. So there's an absolute risk difference of 30.8% with the S3 BTK versus just plain balloon angioplasty. And this was pretty remarkable in terms of its original data, in the sense that we normally use long, slow, prolonged ballooning for below-knee vessels, and this has given us a much better patency rates compared to what we used to do with balloon angioplasty. So obviously, this is a very low reintervention rate of only 6.5% in 1 year, and it's a very durable treatment, especially for patients with critical limb ischemia. There are consistently higher observed rates of limb salvage and primary patency across a range of lesions. And that's all of the data that's here. If you look at primary efficacy endpoint, you will see not only the short, medium, and long lesions, and you can see that the BTK Esprit stent is far superior compared to plain balloon angioplasty. And this continues for a period of almost a year with 92.6% patency rates. So how do you use this stent? I think you have to prep the lesion. You cross the lesion, you either do balloon angioplasty or you basically do an atherectomy, whether you use CSI or whether you use any other atherectomy device, or even plain simple balloon angioplasty, create a good luminal gain, and then basically deploy the stent, which the sizes of which are very important. The first few cases I did with the help of IVIS, because these lesions of these vessels are fairly small, and sometimes you really need to size these vessels, not just eyeball and guess, basically. If you look at the availability of these stents, the smallest diameter is 2.5, and the largest diameter is 3.75. In terms of length, the smallest is 9 millimeters, and the longest is about 38 millimeters. So these are relatively short stents, and sometimes you got to use two. Also keep in mind the cost of these devices too. It's very simple. There's nothing difficult about this. You got to make sure that there are good radiopaque markers that you visualize. And if you have to put two, there should be at least a 1 millimeter of the stent overlap completely. You've got to achieve full expansion and do not leave the scaffold underexpanded. And therefore, the first few ones, if you do with IVIS pre and post, I think you'll get really good results and good apposition. Multiple scaffolds, you got to have at least a 1 millimeter overlap of these patients too. Now, in terms of reimbursement, this is what we do in the United States, and you can see these patients can be done in the inpatient or in the hospital outpatient or in the OBL too. And so you got to keep into account the cost effectiveness of these methods of treatment. And most of the time, I've used these patients for single vessel runoffs that keep on going down. And so you got to be careful as to the exact number of stents and the cost effectiveness of the treatment too. Now, that's one of the stents that's FDA approved, but there are a couple of stents, in fact, that we are also involved in trials. The Riva Medical Motive BTK technology, I won't go into full details, but this is also ongoing. This is the one that we are going to be starting and enrolling very soon, the R3 vascular program, the magnitude bioabsorbable scaffold. We are just been approved for the site to visit, and we'll probably start enrolling these patients in the so-called ELITE BTK trial. This is another very impressive technology. It's called the ephemeral. I don't know whether the study has already started, but this has got multiple short drug-eluting balloon expandable reabsorbable elements. And it's mounted in a single delivery system and is deployed via balloon inflation. So the spacing allows for good motion of the treated peripheral artery so that there's not much manipulation in terms of movements of the thigh or the leg. And I think this one is also sirolimus compared to the other BTK stent that's available. And there have been trials done already, as you can see over here, in animal models, along with OCT and IVIS, and I think the data has been extremely good, and the US trial will be starting very quickly. Then there's the Champion-NIR study stent also, and you can see this also is not completely available as yet. It's more in the coronaries. It is also a sirolimus drug that's involved in this. So the future of scaffolds will be designed as drug delivery technologies. And both of these, whether it be the metallic scaffolds or the others, are equally capable of drug delivery. And I think they're here to stay. But the question, of course, is going to be the cost, the length of these lesions, and whether they can be then put into the SFA and maybe even into the larger vessels. So larger scaffolds, longer scaffolds are definitely challenging for the rest of the vessels that we treat in the infrainguinal revascularization. So I'll present a quick case. So this patient was a 76-year-old. He had a thrombosed popliteal artery aneurysm and basically was in danger of losing his leg because he came with very critical limb ischemia. Multiple attempts at lytic treatment and endovascular interventions and revascularizations were done at the outside institution, and then he was transferred here. So at that time, he underwent a vein bypass to the anterior tibial. We had to literally hook it up to the anterior tibial and then go through the bypass to open up the single vessel anterior tibial. And we were able to salvage his leg, and he was doing fairly well for about a month. He went to Portland, Oregon for some wedding, and then he came back with severe critical limb ischemia and rest pain. And you'll see this is his bypass which we did, which is a vein bypass to the anterior tibial, and you can see there's this short segment. So this is probably one of the ideal cases for a below-knee DRS stent. If you look at his revascularization when we first did it, there was an area of dissection, you can see in the mid to distal anterior tibial, but that we had cleaned out nicely, ballooned it, and we didn't want to put any stents at that time, and we left him alone. And we felt that maybe it was that dissected area that was completely occluded. And that's where we put the Esprit stent, and you can see he's got a huge anterior tibial that is completely revascularized with this particular stent. We did balloon it. We did do, I think we hocked it with an S device, and we did, and then we created a good vessel prep, and then we stented it because of persistent slow flow sort of a dissection. And the guy is still patent now, more than a long time too. So I think bioreabsorbable stents have the advantages of metallic stents, but also have drug-coated and of drug-coated balloons. They offer vessel support, they limit neointimal hyperplasia and late lumen loss over time. Eventually, this scaffold disappears and allows for return of the physiological vasomotion of the vessel. And I think these kinds of technologies are here to stay. The only issue is how large, how long, and what is the cost going to be. But I think this technology is here to stay. So in conclusion, I think bioabsorbable scaffolds, which were really started in the 1990s, are now finally coming into the market. And I think length, size, and cost are going to be very critical in determining their success. Thank you so much, guys, for this opportunity, and congratulations again on drug.